Good morning, everyone. I'm Sarah Keblin. I'm the Communications Manager here at the University of Vermont Cancer Center. Welcome. I'd like to now introduce Dr. Scott Perrapato. He's Associate Professor of Urology and also the Director of our Robotic Surgery Division here at the University of Vermont Cancer Center and Medical Center. So please welcome Dr. Perrapato.
Thank you. Thank you very much. Good morning, everyone, and sincerely, thank you all very much for coming. It's greatly appreciated, and I'm very humbled. There's many unsung heroes at your university, and he usually gets up with no introduction, but I have to at least acknowledge Dr. Gary Stein, Director of the Cancer Center, and Gary is a very noted biochemist, now Director of our Cancer Center and Services, who is a cancer survivor. And so I think couldn't have a more perfect person to welcome you and introduce our program. Dr. Stein. Thank you.
I want to go ahead and extend a welcome to everybody who is here on behalf of my colleagues, and we're talking about the scientists, physician investigators, all of the caregivers, and a staff at the University of Vermont Cancer Center that is really second to none. But I'm also looking around, and I realize that what I'm doing is welcoming back a number of folks. You know, to us, last year was very meaningful. I mean, the discussions that took place, the information that was conveyed was very important. There is so much understanding of screening, prevention by women. And in fact, I should go ahead and just segue for a moment in another direction and tell you that the 7th of October is our 19th annual Women's Health and Cancer Conference. Encourage your female colleagues to attend. You guys should be attending as well. It is very, very important. Because if we look at what is happening with cancer, and this cancer center is really, I mean, a prime example, I mean, of a center that's in the lead in this area. There is a lot that is being done in terms of understanding the treatment of the disease, but prevention and survivorship are critical. And I cannot emphasize enough that it is important to understand the early warning signs, and prevention and screening is essential. So, a couple of things I want to say at the beginning. I've told you what a cancer center does. I mean, it really is right here in the community. You have a leading institution that is making a difference in cancer research and discovery and bringing that to clinical care in a very direct way, so Vermonters have opportunities that are second to none, and there is no reason to go beyond Burlington for the finest care. And in fact, this is becoming a destination site, both regionally and beyond. A program like this is not put together without a lot of insight and commitment from a planning committee. Scott has championed that from the very beginning, and I'm not going to run through the physician investigators and scientists who have been involved, because I know I'm going to omit somebody, and I'm going to be in very serious trouble. But equally important, being able to develop this requires a group of folks who really are partners in everything that we do. Sarah, our administrative director, Kate, Charlie Brooks, who's handled the operations, and I want you folks to give them a round of applause, because we all should be appreciative for what they've done. Like most initiatives that are meaningful, there are funds that are required to make that happen. And the community came together really under the leadership of our Director of Development, Madeline O'Connor, to go ahead and to provide support for this event. It has come from a number of individuals. It has come from a number of the merchants and industrialists in the area. There was the Provember movement. There were a whole series of activities associated with that to focus on the importance of men's health, and that was quite significant in making this happen. So we owe a debt of gratitude to a number of the people in this area and a number of you in the room who have gone ahead and contributed to that. The last thing I just wanted to mention with respect to cancer is many of you are familiar with the fact that in President Obama's State of the Union address, he charged Vice President Biden with having the leadership for a cancer moonshot initiative. And the specific charge was to double the progress in cancer within the next 5 years. This cancer center is playing a leadership role in that and partnering with the American Cancer Society and the American Cancer Society Cancer Action Network. Next Wednesday here at the Medical Center in the Carpenter Auditorium from 8:30 to 10:30, there is going to be a viewing of Vice President Biden's charge to the nation, and then a discussion in terms of what are our requirements and what we could do. So I'm not going to go ahead and say anything more because you've got a program which is outstanding. I really want to go ahead and to be able to participate as a member of the audience. So Scott, thank you.
So good morning and welcome again. It's nice to see acquaintances as well as new faces. And of course, the goal is to spread the word. From an old dog like me, I am glad to have all of the communication people, because what worked very well last year, which we're doing again this year, is this is going to be, the main lectures are going to be recorded and available on media throughout the year. So it'll be accessible to all your friends and others throughout the year, this information. And we're happy to that they can pull that off. So again, men's health is obviously important to all people. It's almost a new category. As we've always, most men have been tight-lipped about their health and such. So there's not a lot of steps. There's some very straightforward steps that hopefully will either be reinforced or you'll see today that we can all take for our health. And it covers all age groups and all men. So what's going to be our program today? Well, you already met Dr. Gary Stein. My charge this year, and I enjoy this charge, but feel free to chime in anytime for questions and such, is to go over a guide to prevention, survival, and empowerment for prostate cancer, which is the #1 issue many of us men will be dealing with in our lifetime. A topic which is getting much more information. Dr. Peter Hollick is going to talk about male hormones and the aging process, and which much more information and practical information is coming out with that for all of us. We'll then have a short break, time to chat in person, and then we'll have breakout sessions, and then we'll have a very timely talk about skin cancer, even though the topic is not just a summertime disease, and then closing remarks. The breakout session, we're really happy this year that Dr. Jean Harvey is going to do nutrition, exercise, and cancer. Dr. Sideropoulos is very knowledgeable in genomics, and genomics, of course, is how my body's makeup, my genes, etc. So it's an individual, so it's what things are important for me to know about myself in certain situations to stay healthy. Integrated medicine, we're fortunate, a local naturopathic physician, Dr. Russo, is going to be talking, and those three will go on. The big one will be in here for us that haven't signed up for the other ones, and we'll go over that with you, but there'll be a session for everybody who might want one. So prostate cancer, a guide to prevention, survival, and empowerment. And I've always kind of taken a very scientific approach to this, and I realized perhaps it is time to take a little personal ownership of this topic and realize that in a lot of information that's out there is true, a lot of information out there is not, but the bottom line is for all of us men is to understand the situation and empower ourselves to stay in good health and to do the things that we need to do for that, because not necessarily someone's not going to necessarily do it for us.
So I'm Scott Perrapato. I'm a urologist here at University of Vermont for 8 years. I'm glad to be here. Just one small correction. I had the pleasure of turning over the robotics charge to Dr. Brian Irwin. And if I mention the name Irwin, he's 4th generation Vermont, so you may know different Irwins. And he's taking us into the next generation with that. So what are my objectives? Well, first of all, why is prostate important? Prostate is important because if you add up non-cancer and cancer, it's going to affect 1 in 4 of us in our life. And all of us guys my age and older, 60 and older, are going to have, you know, issues with urination that may not be an issue, may be an issue. And so I'd like to review that. Who is it important for? And this is specifically cancer. You know, times have changed. That we now know there's certain risk factors that us men may have, and knowing that can keep us out of trouble. And yesterday we learned from Dr. Logothesis, who came up from MD Cancer, how the whole body is intertwined, how good health is really a cancer preventative. You know, we've always said that, but now there's evidence that controlling my cholesterol sounds so simple, but yes, it keeps me from heart disease. It very well prevents prostate cancer. So there's a lot of elemental things. What is early detection? There's a lot of ambiguity with this, and I've had many of you stop me today, is why isn't there a clear message on that? And I'm going to try to clarify that. I've always been apolitical, but today I'm going to be political for the health of men. Treatment update. We'll go over, you hear all the technologies. We're at a very nice time is for men that do benefit from treatment. All the treatments have technological advances, and I thought it'd be nice to review what those are for all of us. Living life with prostate cancer. The bottom line is, with any situation, whether it's just aging or life or heart or lung or prostate problems, we have to live with it. And what we know now is we can live a great life with it. And there's many facets of that, and I'd like to review that and have a lot of you give some, you know, maybe some comments on that as well. So the prostate gland. Well, the prostate gland, it's always fun to review this. What is it? Well, it is a very singular gland. It lives at the base of the bladder. Its job is to make 90% of the male ejaculate. And it makes fluid that has enzymes, buffers. These little glands called seminal vesicles put in fructose. So what's its job? Make the sperm happy to get the job done. So the fluid is the medium for them to swim in. The enzymes help break down certain things, barriers, so the sperm can get there and do something worthwhile. And the fructose gives it energy. So just like going for a walk, you need all those items. So that's its job. The problem with the prostate is as we age, I guess we weren't geared to make it past 30, the prostate doesn't stop. It enlarges. And actually, this is a great model of a non-cancerous, meaning it can't spread, natural enlargement. And so this middle part, unfortunately, keeps growing and growing. And one of the things, so if this is looking in the male's urethra, this is what you pee through. And this surrounding is the prostate. And you're like, well, that's not that impressive, and it's not. That's a 20-year-old prostate, no big deal. This is an example of a ball of tissue in a 60-year-old prostate. So it's not hard to say, if you pee out of that little opening there where that scope is, and that ball of tissue is laying there, you're not going to pee very well. What's the good news? Well, the good news for us guys is we now have medications, and one is actually based on an herbal type, which can shrink this by 30%. So when I was in training, 100% of men with prostate problems had surgery. Now only 20% need surgery. And that surgery has been, you know, modified and quite perfected. So this is an example of something all us guys are going to deal with, the bladder being unhappy, going a little more often, getting up a couple times a night. We consider natural. When it gets worse than that, we have to deal with it. So this is a cut prostate. So this is that ball of tissue you saw cut in half. So the white here in the middle is the urethra. That's where the urine comes through. And what's easy to see is this prostate has 2 areas. And you can see it. It's got this horseshoe here, and that is true glandular tissue. And that's actually related to breast glandular tissue. This middle part, you can see these balls of tissue are the non-cancerous enlargement that all us guys have as we get older. This is the part that affects urination. It's not a cancer. It does get bigger. You can control most with medicines. If you can't, put a little laser in here, open that up, and life's good. What's our charge today is why do 1 in 15 men have a prostate cancer? And like all cancers, the bottom line with this is a magnified view. This is, under the microscope. These are all those glands and cells. And just like other cancers, and especially breast cancer, you have enlargement that's not cancerous. You have enlargement and cells get a little bit crazy. They forget when to stop dividing. That would be, you'd consider a mild cancer, all the way to cancer cells that could spread and could affect our life. And the bottom line with prostate is that, yes, we have to be careful or identify if we're developing cancer, but the second issue is identify the number of men, which is about 30%, where that cancer can affect me within 5 years of it developing. So the issues with prostate cancer aren't only, hey, can I prevent it and such, which we'll talk about, but if I'm going to get it, how do I find it early? And then the second question is it a good cancer or a bad cancer? So it's a tough issue, but it's the same issue women face with breast cancer and other cancers. So our goal is to find the 30% of men with prostate cancer that could affect their lives, and those men benefit most from treatment. So I always show this 2003 slide because it's good news, bad news. This is the year that the prostate cancer passed colorectal cancer for the second most common cancer deaths in men. But what's important is it's common. So when you look at how many men are going to get prostate cancer, of the cancers a man can get, prostate is by far the most common, just like breast the most common in women. And the fact that hasn't been really put out there is the same number of men are dealing with prostate cancer as women with breast cancer. And that's important because a lot of men get prostate cancer and they're like, well, I can't be getting this, because it's not a common cancer. The other issue is, again, it's still the second most, and breast is the most common causes of losing a man early in life. So it is a significant issue. So it's not, when I grew up, it's like, well, your grandfather has prostate cancer, everybody has prostate cancer and lives with it. That may be the case in 6 out of 10 men. You can control prostate cancer or watch prostate cancer for a lifetime, but it's the ones that are that 30% that could affect our life. The other thing which is important just to mention is you see how lung cancer is not as common, but man, it's very bad cancer. As you know, there's some very exciting initiatives now looking at screening for lung cancer, which we never had before. So if I've got a 30-pack year smoking history, I worked in some certain industries where I had a lot of lung exposures, they now can do a very low-dose CAT scan screening. And you'll see that if you don't know people who have had it done. And it's very exciting because for every lung cancer you find early, you really impact that person. Because if you say, what cancer can I really make the bottom line better, it could be even lung cancer. So this is an exciting slide and not an exciting slide. So basically this is prostate cancer when we started keeping good numbers, and SEER means state by state data, and the number of men with prostate cancer we started to identify more, the mortality was going up, and then there was a time when we developed a blood test to find prostate cancer earlier, and then understandably after that, boom, the mortality started going down. One thing I have to add, and this is editorializing, is already with some of the ambiguity in the United States on early detection screening of prostate cancer, these numbers are going up. So we have to find a common ground of detection without detecting too much. So we have a very wonderful Vermont State Department who keeps very accurate numbers, and this just puts home the obvious. In Vermont, just like everywhere else, whether you're in Belgium or here, prostate cancer is common. It's 25% of the male cancers, and men succumb to it. This is important because this tells you the story of any cancer, and you're going to hear it with skin cancer today. Melanoma is a type of a skin cancer, and if you find the cancer early, the cures are expected. If you find it when the cat's out of the bag, either in the area or distant, that's the problem. So prostate cancer, we've been able to find in Vermont 80% at its early localized stage. However, that number is going down again, and I have to keep reiterating that because this is our biggest problem now because of the ambiguity on how do you do screening. So that's kind of sad, so we've got to work on that. Colon and rectum is a huge importance. The amount of colon cancer found early used to be like almost nothing. Now it's getting a simple colonoscopy that we all say, I got to drink that stuff again. It's 5, 10 years. But this amount of localized colon cancer is going way up higher now. So early detection, any cancer is going to be better. So why do us guys make prostate cancer? Well, you're going to hear a number of reasons that we know today that we didn't know 5 years ago, which is not that long in medical terms. But what we do know is as we get older, our bodies, whether there's certain changes or we can't fight the changes, we develop more cancer. The other thing we know is family history is important. And there's different types of family history. But if a family member, my dad, my brother, had prostate cancer, my risk is higher. The other thing is area geographic differences. So I grew up in North Jersey. We actually had a higher prostate cancer than someone living in Westchester County. Now, what was one of the differences? Well, we found out, epidemiologists, that it was diet. Because if I eat a high fatty diet and my weight is, I have extra body fat, that your estrogens change and it could affect a possible chance of prostate cancer. And that was an observation. Now that's been improved through the fact that, hey, it's not so much diet of what we're eating, but how our body handles it. So what you hear nowadays is metabolic syndromes, Scott has diabetes at age 55 and other body functions, my cholesterol's out of whack. Those are metabolic syndromes that aren't our fault that can happen. So what we now know is this diet means that, and that by simply controlling our cholesterol, identifying diabetes and other metabolic syndromes and controlling it, your chance of cancer goes way, way down. And that is huge because we've always talked about it, but only recently has there been really hard facts. And you're going to see that. So heredity, what do we really know about prostate cancer today? Well, what we know is hereditary prostate cancer exists. Fortunately, it's only 5 in 100 men, but you know them. I have someone come to see me and they go, my 3 brothers have had prostate cancer, I'm the youngest, and my doctors checked me and I have an abnormality. That person's going to have prostate cancer. It's a very defined chromosomal change. You can't miss it. Thank God it's only 5%, but if you're in that family, you're going to start your checkups a little bit earlier. The most thing that's been the biggest impression on men, though, in the last 10 years is the breast cancer gene situation. We all know Angelina Jolie. She was very brave bringing this to the forefront, that there's a genetic change that women have that predispose them to breast, ovarian, and other cancers, and many basic scientists did an incredible job that, in short, the repair, our body's always changing and cells kind of come out wrong sometimes, the DNA isn't right, but the body fixes it. Well, in this situation, our body, it's like not having those repair people. And we're at risk for cancers forming because we don't have that repair system. So anytime someone has this genetic trait, which is genomics, then they're at risk. If they're a woman, they're at risk for breast, ovarian, and other cancers. But guess what? Men can get that gene change. And guess what? 75%, huge, will have prostate cancer. And they'll have it at a young age. And they'll have significant prostate cancer. So this has been the hugest thing. So I'll see men and family doctor. My wife's a family doc. And and she'll be talking to people, and they're like, why are you asking me about my, the women in my life? Well, that's why. So it's important, it crosses over. And if you said what would impact most men in the world today, it's knowing that status. And that status is pretty straightforward. It's unfortunately because the family will tell you my aunt had breast cancer, my sister had ovarian cancer, and the history you can't miss. And this is where genetic, and by the last thing is first degree relatives, you're at a little risk, but not absolute. The thing I love telling men is, yeah, your dad had prostate cancer, but that doesn't mean you're going to get it. It's a risk, it's a small risk, it's not huge. Because we're all dealing with the stress and risks, so we don't want to make it any worse than it is. So one of the fields nowadays, which is interesting, is genetic counseling. So I'm worried I'm going to have prostate cancer, and I have a couple family members that have breast cancer. And I have one family member, it might be my uncle, had bad prostate cancer. So I can go to a genetic counselor. They will make me fill out 4 pieces of paper, very detailed question, family history, and they'll know from that whether I'm at risk. And they will talk to me about, hey, Scott, you could be at risk for BRCA gene. And tell me, hey, do you really want to know? And they'll go through the risk benefits, and I can get tested for that. And if I have it, yes, I have to psychologically live with it, but most importantly, I can go to my family doc and say, hey, I got it, and my family doc automatically will say, you need more colonoscopies, you gotta, get these checkups, and hopefully would keep me out of trouble. So that is a huge difference. And I have to admit, at least the people I'm exposed to here in the genetic counseling, they do it very unthreateningly, they're very human, and they get you through it. And of course, the majority of people who go through this don't have a genetic problem, and that's nice, but you gotta know. So what can a man do to lessen his lifetime risk of prostate cancer today? Well, again, a lot of these, you look at it and you go, man, if I was fixing my car, I would do the same thing. So you gotta know your risk, know those brakes are about to die. Prevention, check them. And early detection is, every so often check them. So it's pretty straightforward. But for us guys, it's not hard. So this is a slide which is really fun, and it just says diet and activity. And looking around this room, everybody, I could see knows these things are good for us. But what's interesting is we now know that the cardiac diet is the anti-cancer diet, is the, keep Alzheimer's way as long as possible diet. So the essential thing of the body, which is a wonderful working organism, is diet to be healthy, make sure the minerals and vitamins are available to us, whether you do it through pure foods or do it with supplements in moderation, and physical activity. And this is not a lot. These were really cool, someone sits on the couch for a week, someone gets up and does activity, and they showed improvement in every physical attribute you could think of, from stamina, feelings of well-being, less incidence of diabetes, better cholesterol, less cancer. It's very straightforward. And the thing is, it doesn't mean you have to get out and run the Vermont Marathon. It's 5 days a week of 45 minutes of fast walking, which I think is probably the best exercise any of us can do, because you can enjoy it while you're doing it. So these 2 entities in every individual, whether you know it or not, lessens your risk of cancer. So what are the good and the bad news? Well, we've been looking for ways to prevent cancer. We do not have a magic bullet to prevent cancer, and I'm sorry to say that. This was a study all of us in urology cancer were involved with. This was the only NCI-funded study for men for prevention. It cost $82 million, and I had to have 35,000 men participate in this. It was very well participated. And the question was, the thought was vitamin E and selenium in small studies decreased several cancers, decreased lung, colon, and prostate, and breast. And so they said in men, hey, well, let's see if it really works. Because as you know, I could tell you, this is true, but you really need to test men. And then obviously for prostate cancer, this was a long study. So it cost $82 million to give 4 options: vitamin E, selenium, nothing, and both. And these men were great. They took what they were supposed to, they got checkups, and then they said, they look back and say, hey, what was the incidence of cancer? Unfortunately, the same. So overall, we can't say this. What we can say, there are subgroups that benefit. So I guess the way I look at it, and correct me if I'm wrong, is if we're depleted, like selenium, certain selenium you get from food, but in certain places, the ground is such that the plants may not have the selenium. So I take moderate supplements to make up for what I don't know is in the food or not. But the thing with guys is a little is good, a lot is better. Don't do that. Anything that's an A, D, E, K vitamin, you can build up and be toxic. Selenium also. And there's always fun ways to know. Selenium, if you take too much, your nails get really brittle, almost fall off. And I can tell you over the years, I've sat with someone and I'm looking at their nails and, you know, it comes out that, yeah, I'm taking handfuls of selenium. So it is an interesting, there's too much is not necessarily good. The other two things which are important to know is, I told you we could make 8 out of 10 men better without prostate surgery for non-cancer. And one of the cornerstones, which incorrectly I call synthetic herbals, are a medicine called finasteride and one called dutasteride. And they, in prostate cancer cells only, block this one little conversion of this enzyme or this hormone, dihydrotestosterone. And with that, those dividing cells don't divide. And prostates actually will shrink by up to 30%. So, well, what they found was when they used these, hey, less men seem to have cancer. So this is where our understanding of cancer has changed. And notice I talked about a spectrum from normal cell, little bit of cancer, to bad cancer. So what we found is these two medicines, which are, you know, wonderful for making men urinate better without surgery, they will decrease the number of not so bad prostate cancers. However, they don't affect the significant, the 30% of men who have bad prostate cancer. So they're not approved to prevent cancer, but just you'll read about that quite often. But we use them very commonly. Family doctors use it even more commonly to treat men. They're great, they're safe. Important thing is they don't take away the risk of significant prostate cancer. There's also a myth that these things cause bad prostate cancer. And on one of them, there's actually a little box that says it could, because back then we thought it did, but it does not. So what do? You've done all that, and you're like, okay, I'm at a little bit of risk. Again, a lot of people that I've talked to, I don't like the word screening. The word screening means I'm going to check every guy in the world and do everything I need to see if there's a cancer or not. I don't want that. And the same for ladies with breast cancer. We want early detection. We want to find a significant cancer, if it's going to form, at an early time. It's a big difference. And I was involved in screening. We did PSAs and biopsies on 1,000 men, in the one study I was involved in. Every Saturday, all these men would come in and get biopsied for years at Michigan. But that's not the answer. The answer is to be smart. Do the tests that give you the best return. Make sure they're accurate. And because of this, we were fortunate. When I first got here, the doctors before me had shown that by just looking at the data a little different, they would actually biopsy 40% less men than where I was from, and they found the same cancers, bad cancer. So they are already showing that if you look at these tests a little differently or repeat them or look at some of the newer tests, you don't have to do a biopsy. And a biopsy is when you actually put a little needle in the prostate to get tissue. So what do you got today? Today it's very simple. A physical exam to look for lumps and bumps is not super sensitive. However, if I come in with urinary problems, I have other abnormal tests, a physical exam is important. The big money still is a blood test, still is a protein that is made by good prostate and bad prostate called prostate-specific antigen. How we handle that blood test, though, is very different. And if I have my yearly blood test and it's abnormal, what am I going to do? I'm going to repeat it. Okay? What am I going to do if it's a little bit out of whack? I'm not going to run to a biopsy. I'm going to get it every few months and see what the trend is. So there's a common sense way to approach it. And nowadays, there's 2 tests that have variations on that that clarify this test. So that I have a man, his PSA is up a little bit, not super scary, but he has a family history. We may get this test and it may say, hey, this is not a bad PSA for this man, and we could safely watch him. Or it might say, hey, this guy's at risk. So it's easier to talk to the man and say, hey, it's worth, you know, the little bit of uncomfortableness and a little bit of risk of a biopsy to know what's going on there. So this is a brutal slide, but it is the most important slide of early detection. So what's the story? The political story is the U.S. Task Force is a group. It is a very accurate, a very scientific, a very above-board group that looks at certain tests and recommends whether they should be done or not. And they looked at PSA alone before 2010. And in 2012, they came out with a statement that said, don't do isolated PSA as a screening test. And they're right. An isolated PSA is going to have me in early retirement biopsying hundreds of men who probably don't need it. However, what they did not do, they did not come up with any guidelines. So they basically said, I'm taking away your tire pressure gauge. You figure out whether your tire has enough air in it to drive at 220 miles an hour in Monaco. So what do? Well, everybody in Canada, in Europe, in Asia, and the American Urologic Association, who, you know, are charged within themselves, have come up with guidelines. So what I'd like to propose to you is, yes, the U.S. Preventive Task Force was accurate. The one problem, and I'll take credit because I'm part of the medical community, which we failed the public and every man, was in not coming up with guidelines at this alternative guidelines. So I think there is a common sense approach, and I think what you think is very simple. Men who are at risk of prostate cancer, the prime of their life, has age groups. So between age 55 and 70, men should strongly consider getting a blood test, a PSA, a checkup with their family doc, but more importantly, they should sit with their family doc and say, hey, should I do this? And if I do it, what does it mean? They're going to say, well, if you do the test and it's crazy, I'm going to do it again. If it's crazy, you're going to see a urologist. And, you know, it may be as high as 50% you're going to end up with a biopsy. Is it worth to you to know you have prostate cancer? And the second thing is, and this is even more important, the guys that are at risk. So I have BRCA gene, and I'm 40 years old, and I know it. Europe showed this, and England showed it really well, that if you get those men between 40 and 50 should have a PSA. There is no doubt. If that PSA is super low, they have incredible confidence they're not going to make a significant cancer for 10 years. And then they go into the regular screening. If it's abnormal, those are the men we want to find. The man who, you know, I saw 2 last month, and I'm sure Dr. Hollick has seen them, that walked in at age 48 and 49 with widespread metastatic prostate cancer. So those are the men we want to impact. So the simple answer, which is not so simple, is men 40 to 50 should talk to their doctor, but when they're at risk, should strongly consider a PSA, because I think the vast majority of them, 95%, are going to have great confidence, hey, I'm okay, and I don't need, you know, a test for a long time. And at that age, you know, they're getting into life, and it's a scary time to think about health issues too. The second thing is, all of us healthy men between whether it's 55 and 70 or that, if we're in good health, should consider talking to our doctors about screening, which would be a PSA and a checkup, and then go down that road. But I think it's a common sense, and the amount of men from this system, as you could hear, the people getting biopsy recommended is much less than the past. However, if I have that abnormality or that risk, you still have to go through a biopsy. It's a needle in the prostate. I like to think we can get through all men without much fuss, and I strongly believe that, just like women went through that with early breast biopsies. However, there is a 2%, means 2 in 100 men, we can give them a really bad infection. And some of that is the resistant bugs we've created. So it's small, but it's real. And if you end up in intensive care unit here, like we have, you know, a couple people every couple years, it's not fun. Fortunately, 98% of us will not have an issue. Then the ball goes over to the pathologist, because second part of the issue is, I've got prostate cancer. Hey, am I in the 60%, 70% that it ain't going to bother me, or is this real? And that's where the pathologist is so important. We're very blessed here. We have two, world-renowned prostate pathologists, but you have normal cells, you have almost normal cells, you have cancer cells that might not bother me for 10 years, and you have cancer cells that could bother me next year. So the pathologist is key. The pathologists are not inactive. They're always looking at what they're doing, trying to do better. So they actually just recently shortened the number. We used to have prostate cancers. We give them numbers. There's so many, 2 to 10. Now we're giving them 1 to 5s. So at least it's easier to say, okay, I'm a number 1, I'm a number 5. So you know where you are. Sounds simple, but believe me, when I tell someone's a 6 and someone's an 8, and they're like, what does that really mean? So again, knowing that pathology is better. What's the second thing? Well, finally, we're at that level below the cells. I mean, I look at this to humble myself every so often is, which one of I can't tell the difference. The pathologist can't tell the difference. One of those is a cancer that went on to be really bad. And that's the difference, is molecular biology, where they look at certain characteristics of what those cells are doing. Are those cells more able to move? Are those cells more able to divide? Are those cells just going to divide faster? And molecular biology, looking at what that cell gene is doing, is a big difference. And they're doing that in many cases. And some of this testing is now standard. So preventive, the other thing with prevention is, okay, I've got prostate cancer. The two things as a guy I want to know is it just in my prostate, organ confined? That's curability. The second thing is, what are the treatments? What is it going to make me disease-free or not? And we now have very sophisticated statistics made for us that when you sit with a man in the office, you can say, hey, you got this situation. If you did nothing, nothing would happen for 10 years, which sounds funny, but that situation exists very commonly. Or you have this other situation, say you have this situation, which is a combination of your blood tests, your exams, your pathology. This could affect you in 2 years. You should think of treatment. So we have a lot of help in this regard. So that's been helpful. So getting back to the individual cell and genomics. So the one thing with a lot of the cancer cells now, they have features that we can measure. The biochemistry world is taking over, thank God, because we've gone as far as we can clinically. So by looking at these different tests, these genes, how these cells function, basically you can basically say, hey, I'm way over here, I'm at a low risk, or I'm over here, I'm at a high risk. And it is wonderful to be able to sit with a patient who has a middle-of-the-road cancer who we don't know should even have treatment, to give them more scientific information for that. And this is another example of it, of what kind of information. And it sounds funny, but this is the way cells get out of hand. So if cells can handle stress well, and believe it or not, there's genetic parameters of that, then you have a better outcome, because they're not going to defect and become bad. Cells can't migrate so well, they can't get out of the barn, you're going to do better. However, some cells say, hey, I'm never going to turn off, I'm going to proliferate, I'm going to divide. Bad news. Some cells can get out of their homes, their extracellular matrix. That's bad. So you can now look at those cells and say, hey, what kind of cell is that? It's kind of like the combine, the NFL combine for cancer cells. And you can then take a person and do a biopsy and say, oh, you got cancer. Hey, look, the genetics of that is incredibly good. You go to surveillance. You just get checkups. And if something changes, you have a repeat biopsy, and then we do it again. However, if you get certain parameters, you're like, this is not good. This is going to affect your life. And this has been done for breast cancer for many years, a test called Oncotype, which actually is a dividing factor of many women who have early or well-differentiated breast cancer and whether they get treatment or not. So there's a lot more information for us guys to do that. So what if you get prostate cancer? What if I'm unlucky and one of those men that have a nastier prostate cancer? Well, the good news and the bad news is you need treatment, or should think about treatment if you're in good health. The bad news, the good news is you have equal options, and that's really hard concept for men. So I'll see many men, they have a cancer, and it's like, you can do different treatments. I'm just going to go over what's new and different. First of all, this is the most important slide. This is a gentleman who is in the 60% who has a cancer. It's not a bad cancer. All his genomic testing says this cancer is not going to misbehave the way it is today, and they don't have to do a darn thing. Active surveillance. They could watch it. They can get a blood test every so often. If it changes, they could have a biopsy, and basically living with cancer, a great life, and that would be our goal if we did have that finding. But all the technologies at this time are getting better. Radiation therapy, the ability for this linear accelerator to flip around so we radiate just the prostate, not the tissue around it. Less side effects, get enough radiation, curability. Robotic surgery, using little instruments to totally remove a prostate, and the cure rates for these two therapies very often are very equal, so men have a choice. If cancers aren't terribly aggressive, putting little radioactive seeds in the prostate where you're radiating even more focally. The two newest treatments, well, cryosurgery is freezing the prostate, getting better all the time, a little more side effects than the others, so you don't see it that much. HIFU, I had to mention this because it's been in the Wall Street Journal numerous times in the last year. HIFU is, you can turn ultrasound frequency high enough to cook an egg. So somewhere in between you can treat tissue. So with a transrectal probe you could put high frequency ultrasound. The problem with that is to get enough energy, you can't use high enough energy to get the bad cancers, so you can it's only FDA approved for some of the milder cancers, but it is available. So that man that may not want to go on active surveillance and this treatment is eligible, they can have that done in the United States now. Previously they had to travel out of the United States. So as you can see, all the technologies are getting better. This is interesting. This is a unit we're going to get, and you notice it's like the old Taggart's driving school. They're side-by-side consoles, because people always ask me, how do surgeons learn how to use this thing if only one person can touch it? Well, now two people can touch it at the same time when they're doing surgery. So the other thing, and David Kramer, who is working with the Survivorship group of Vermont and is here today, will definitely agree with, is whether you're going through checkups, whether you have cancer, is survivorship. So many men, millions of men are living with prostate cancer or post-treatment, and it's a crisis. Any support that these men get from family is so worthwhile. Men tend to be quiet, but when they do huge surveys and they get the men alone and the doctor or nurse is not asking the questions, what are the issues to a guy? Well, financial health. The first thing a guy thinks is, wow, how am I going to, help my family if I can't work or this? And they can work and they can do things, but that's a number one concern. How do I, guys don't tell you that they're just not feeling well. They're out of equilibrium. How about the caregivers? When people go through treatments, when I walk out of a surgery, the patient's asleep for 4 hours. The family looks like they were run over by a truck. It's terrible on the caregivers. Sexuality on cancer, we never talk about it. Sexuality and support should be able to keep men very healthy and close to a normal situation. But again, men don't talk about it. So all these factors, have to be taken into account for that. And for that, we have lots of help. In Vermont alone, the Survivorship Network in Vermont is phenomenal, started by people with cancer. Vermonters Taking Action Against Cancer is a group that mediates a big grant to the state to, hey, we want an action plan so we can help people stay healthy, prevent cancer, find it early, support them. And the Vermont Taking Action Against Cancer group is here. Ed Demure and Jessica French, one of the co-directors and the new coordinator, which David Kramer did for many years and started the group, is here. Talk to them. Look at the Vermont Cancer Plan. There's great information. When I see people, they go, we need information. This is one site online. You and I can get great information on, cancer and how to tackle it and the support services. So please take advantage of that and spread the word. One quick blurb, which I have to sneak in because it's a low number of men will get testis cancer. The problem is young men get it, and it affects their life. And this is a case where politics butts oncology. So testis cancer is easy to find. You tell high school kids, hey, you get a mass in the testicle, you tell your doctor. It's really straightforward. And men between age 18 and 50, that's the age range. So the present family practice says, no, we don't teach men to look for that anymore, because if you find it and it's spread to the first step, you can still cure it 96% of the time. And we save men getting extra ultrasounds and psychological trauma coming to the doctor. Well, what's the problem? The problem is if a man finds a mass early, is treated locally, they don't get chemotherapy. They don't get radiation therapy. They don't have 50 years of worrying about a secondary cancer or side effects of my treatment. So this is one of the dilemmas about, detection. There's a common sense. I think men need to be educated on what to watch out for, and have a common sense supportive system to see what's going on. So my spiel on testis cancer is, even though you can look up guidelines and I can, it says, nope, we don't tell men to check themselves or do anything. The rest of the world does. And there are huge programs in Australia and England and Europe that are basically, your life's in your hands. And that goes to prostate cancer too. Be knowledgeable, be proactive, talk to your doctor. Family doctors and providers are phenomenal. They know the scoop, and they're happy to sit and talk to you about, hey, this makes good sense. And if it doesn't, they'll tell you. So really appreciate your attention. Thank you very much. Any questions I could tackle? And we'll have plenty of time later on. Yes, sir.
Who do I best say my question for? One, energy. It's not there about midday. Violence of going downhill. Secondly, nutrition. What should I be eating?
Sure.
73 arthritis.
Right. Well, you nailed it. You're like the perfect lead-in, because Dr. Hollick's going to tackle the energy, and then the nutrition, maybe we'll come back to that in a little bit. But nutrition is a good balanced diet. It's well, written in, even the VTAC site has a great section on that. But we could also come visit that at the end too, if the question's not answered in the next talk. Thank you. Yes, sir. Dutasteride. Yeah.
Would that be similar to Flomax?
Good question. If my prostate's blocking my urethra and the pee's not coming out, two families of medicine, finasteride and dutasteride, will shrink that prostate by 30%, but it takes 6 to 12 months. The other family of medicine, Flomax and such, are relaxants. They'll relax it that day. So sometimes we have to use both. The one to relax it, so get the urination symptoms better. The other one, if the man wants to physically shrink it. So they work kind of in concert.